In this video, let's discuss about this ECG. So what is the rhythm? The rhythm is regular. Now the rate, I'm using the R wave method. So I'm taking a 6-second portion. I got 15 R waves. So 15 into 10, it will give a value of 150 beats per minute. QRS complex, that is narrow. Now I'm looking into the P wave. I cannot identify the P waves. So a regular rhythm with narrow QRS complex with absent P wave, I have to think about supraventricular tachycardia or SVT. More specifically, this is an ECG of AVNRT, atrioventricular nodal reentrant tachycardia. Normally, your AV node is having two pathways, one slow conduction pathway and one fast conduction pathway. Slow conduction pathway means it will carry the impulse slowly, but it is having a shorter refractory period. But in fast conduction pathway, the refractory period is longer. So when a impulse reaches, it will enter into both slow conduction pathway and the fast conduction pathway. The fast conduction pathway easily carries this to the ventricle and that causes a ventricular depolarization. Some of the impulses will enter into the slow conduction pathway from the bottom portion. Already your slow conduction pathway is carrying some impulse and these impulses are get neutralized and a re-entrant circuit is prevented here. But if a patient is having some ectopic foci and that created some premature contractions, these premature impulses will reach as AV node. We have mainly the three types of AVNRT. I'm not going to tell all the three types. I'm going to tell about the most common. The most common AVNRT is the typical AVNRT. So in this, the slow conduction pathway is now ready to carry the impulse. Your fast conduction pathway already carried one impulse and it is now in a refractory phase, in a recovery phase. So this slow conduction pathway carries this impulse and that reaches the ventricle and that causes a ventricular depolarization. During this time, your fast conduction pathway become activated. So some of the impulse will enter into the fast conduction pathway and reaches the atria. From the AV node, it reaches the atria that causes an atrial depolarization. That means the atria and the ventricle contracted simultaneously. That's why the P wave will get buried within the QRS complex. That's why I cannot identify the P wave here. This is a typical feature of the AVNRT. Sometimes the P waves can be seen, but it occurs after the QRS complex and it appears as a pseudo R wave or a pseudo S wave. The pseudo R wave can be seen in V1 and V2. The pseudo S wave can be seen in lead 2, lead 3 and AVF.